This could be fun. It will be.
Well, good morning and welcome back for the third day of what is being thought of as, I think, a very successful Venous meeting. And we have a very good panel this morning to discuss IVC filters and more DVT intervention. And we're going to start with Dr. Miguel Montero Baker from the University of Arizona, Division of Vascular Surgery. And he's going to speak about an interesting case of using trellis, right? With IVC occlusion. And I have a couple of housekeeping issues just to share with you. And again, reminding that people with podiatry and RTs need to sign in each day. It's not nursing. I made a mistake yesterday. And for the CME credits for physicians, it will be available online after the 13th. So there are instructions that are in your handouts or that you got with your bag. And or it will be online anyway if you lose those. And then you can get your CME credits electronically. And I want to thank Dr. Golzar and everybody for all the nice events in the evening. And with that, we'll get started with this morning's first presentation with Dr. Montero Baker.
And we have the clicker around here. It is around here. I knew it was around here. Thank you. Well, sure will tell you it's an honor to be up here, sharing the podium with some of the people I consider mentors and heroes who I look up to. This is actually not a single case presentation, but a case series that is in the process of being submitted to the Journal of Vascular Surgery. I do have to say this was done in conjunction with my partners, Dr. Leon, Dr. Branco, and as a friend that we always publish together, Nikos Labropoulos. So in any case, I don't have any disclosures that actually relate directly to this procedure or any of the devices used in this procedure. I think one of the potential lethal complications that we see as we evaluate more and more IVC filters is as we leave them there for a longer period of time, then complications come from that. One of the worst ones in that scheme of things could be then the complete occlusion of the IVC. We do know that there are at least 18.6% of clot residue, and this is on CT analysis of IVC filters. Some degree of burden in and around the filter. That could be because it's been caught or that it has actually been formulated in situ. 2% of those patients have actually been found to have IVC occlusions. The mainstream of management, at least for a while, has been optimizing medical management for these patients, putting them on systemic anticoagulation, and then managing their post-thrombotic clinical complications that tend to be fairly aggressive. So what we did is we don't have a huge center, but we do a good amount of venous and arterial work. We look back at our charts as to how many IVC occlusions related to filters we had. And then we diagnosed that via either a duplex or a CT scan and then confirmed that via venography. We did utilize the K-trellis technique, which means nothing but kissing trellis. And I'll walk you through a couple of the technical issues related to that. And we had a success rate of above 75% in clot removal. There was adjunctive endovascular therapy in most of the cases. And that included basically either stenting to optimize the IVC lumen or just balloon angioplasty. This is a typical CT finding that you'll have. You will have your IVC that normally is distal to the filter occluded, but it remains patent due to the inflow of the venous outflow of the renal veins. So normally it will keep patent above the renal veins. So that's why actually, technical tip is for those people who don't do a whole lot of IVC filter placements, you do have to place it there because of that reason. If you would put the filter above the renal veins, then that is something you might potentially find. And this is one of the classical findings of patients that have occluded IVC filters with all the clear collateral pathways. So as you see kind of the broad table of demographics of the patients we had, a total, pretty interestingly enough, as we only found 2 of them that were clearly found to have a prothrombotic state. One had antithrombin deficiency, and another one had a full-blown metastatic cancer that actually died shortly after the procedure, and not related to the procedure, but probably to the advanced state of his disease. The rest of them actually look more like arterial issues, but not related directly to that. The indication from most of the patients, and understand that most of these patients were actually on anticoagulation, but one of them, their INRs was actually below therapeutic range, but they were all theoretically getting some sort of anticoagulation. The reason for them, as you can see it down below, were the reason why they had their filter placed, and I think that relates directly to what we did. So this is just a small little chart to explain what the K-trellis technique is all about. There's actually just two case reports in the literature of utilizing this device for IVC. This is, be mindful that for CME issues, this is out of the IFU of this device. This device is actually marketed to treat iliofemoral DVTs. So what we do is actually we float the wire. We usually use Terumo, guide wires. We float the wire through the clot burden and all the way into and past the filter on both sides. By doing that, then you practically secure the access to advance the device. For people who do not have any experience with the trellis device, this is a device that's over the wire. So you could actually float the device through this wire, and it traverses fairly easily through the clot burden and the filter itself. Once you're there, then you'll remove the wires and advance the inner cannula, which has the oscillating wire, and then inflate balloons distally and then proximally, to some extent, quote unquote, creating a space that is independent from the rest of the circulation, or at least so it's said by the company. There are no trials right now, nor research that I know of, and I'd love to hear the panel if there's anything, that have actually determined levels of TPA systemically. I do believe that there's probably a whole lot of that TPA that does make it out of that closed, quote-unquote, space that the device creates. And then you activate that device, which starts the oscillating movement. Now, one of the early criticisms that we got was that we were told, that could be crazy. What happens if one of the wires would hook onto the IVC filter and then you're stuck in a worse place? Well, I mean, it would really have to be hard because most of these IVC filters have been placed there for a while, so they are well incorporated into the wall. And the other thing is that this wire does not rotate, so it's not like it's going to catch in any way. It's not doing like a swinging rope. It rather just oscillates back and forth. So you're just kind of creating vibration and disruption of clot rather than actually kind of catching it in a whiplash manner. So actually after all these cases, we've had no technical issues. None of those cases have actually engaged in any way into the filter. And bear in mind that we have used the majority of the filters were Cordis filters, and there were a couple of, I think, Select in that trial. So most of the procedures were successful, but one, and again, the success of the technical procedure described as more than 75% clot blood burden removal on venography. This is one of the cases where you would see the occlusion related to the IVC and the filter. As you advance the device, as I showed it before in the little chart, and you put them both in a kissing fashion all the way up, then you activate that. Then I would say every operator I've seen does this in a different way. We'll usually put 1 to 5 milligrams initially, and then we'll give every minute that we change the oscillation patterns, we'll give an additional milligram of TPA and so on and so forth to reach a total of 10 milligrams. When we do the Kate trellis, we are a little more liberal, and sometimes we will go up to 15 total, 7.5 on each side. At the end, you will find that most of that burden will go out, as you see in this follow-up post-initial trellis. And this is the recurrent thing that we see by most of these pharmacomechanical thrombectomy devices, is that you will have some burden left. And that unfortunately the aspiration ports of this device are pretty miserable, so we don't even actually, the step of aspiration that this device proves, with the apologies required by the company, are really useless. So we don't even do that step. As you see, what we do is we actually put 8 French guiding sheaths, and we just manually suck by moving, in a cautious way, not forcefully up and down, to not create, a whole lot of endothelial damage. But we do get a very impressive amount of clot that comes after the pharmacomechanical lysing. It kind of makes it into a sludge to some extent, and then it's fairly easy to suck, which, I've always thought there's room for improvement to create a device that could be angled into the walls, and that could have maybe a motor or a system that you could suck some clot out of. This is the result after the sucking of the clot, and then sometimes we'll optimize that with some balloon angioplasty. I will be honest, we won't go for the filter at that point. If there's a clear indication for the filter, we'll try to optimize anticoagulation, keep the filter in place. If there is a soft indication for the filter, which unfortunately is the case in a lot of these patients that have been forgotten in time, we will come back a couple of weeks later if the patient is doing fine, and we will try from the internal jugular, or depending on what the filter placement was, we'll try to take that out. So the mean hospital stay on those patients was 2 days, and then they were discharged. We have follow-ups up to 233 days, oscillating from 4 to 1,058. All of them had clinical follow-up and were asymptomatic. Only 3 of them, unfortunately, had actual imaging of the IVC that we could look at. And again, this is a retrospective analysis. One of them was actually retrieved, as I said before, at 45 days. One with the one died, which was the metastatic cancer patient. So we think that the K-trellis technique is effective in minimizing the clot burden, and I say minimizing, I don't think it deals with it, related to an occluded IVC and filters in a safe manner without interfering with the mechanical structure of the filter itself. And we certainly need to further investigate with larger series and patency rates post-recanalization of the IVC. I do appreciate your time and your patience. Thank you.
Thank you. Thank you, Miguel. And now I'm going to talk about whether or not there's an indication for IVC filters routinely in thrombolysis. It's a question that Dr. Golzar asked, and I consider it sort of an assignment. And at the risk of being a hypocrite, we're going to go through some of these slides, and I'll show you that almost invariably we do not use a filter, but I'll show you some of the reasons why that we don't. So I think that'll be new information for you. Should IVC filters be placed at all? Might be the question, not during thrombolytic therapy, but whether or not they should be placed anyway. Dr. Greenfield did a study that showed that the majority of filters are placed in the last 2 weeks of people's lives in the ICU, who are already in the ICU. And so within 2 weeks of having a filter placed, most of these people die. So the question about IVC filter placement at all, I think, is up for debate. But there was an article that came out in 1998 in the New England Journal of Medicine that discussed the efficacy, and from that you can deduct the whether or not it's necessary, putting filters in people who have proximal DVT. And it was a large group out of France that did this study, and they did a randomized 2x2 with some structure to the study, 400 patients who were going to either receive a filter or not a filter, and then they randomized them to get Lovenox versus IV heparin. And measured the rates of recurrent DVT, PE, and at 12 days and 2 years. And the interesting data was that the PE with IVC filter at 12 days was 2 in the group with filters and 9 of the group without filters. And that wasn't really statistically significant. And recurrent DVT at 2 years, there was a trend for more in the IVC filter group, maybe because they were taken off Coumadin, because they already had a filter. A lot of people confuse the need for anticoagulation, thinking that a filter is going to protect them from more DVT, but of course it won't. So those are the data. Pulmonary embolus by itself at 12 days showed that with Lovenox versus IV heparin, it was pretty equivocal statistically. So they concluded in their study that there was equipoise between Lovenox and IV heparin, and that there was no difference in mortality or any other parameters in the patients who had a filter versus not a filter. So that 2 years isn't really long term, but it didn't show that a filter gave anybody a particular advantage for morbidity or mortality. So when we're doing a procedure like Dr. Montero Baker just showed us, I mean, how worried are you that you're going to end up with a pulmonary angiogram that looks like this? And I can tell you that since it's all evolved, and since Dr. McNamara first started and showed us that you can put a wire through fresh thrombus like cutting butter, and we put catheters in there and carefully just parked a catheter and started lytic therapy on venous thrombus, the incidence of PEs like this is almost negligible. And Dr. Katzen published a study, which I looked for, but I'm sorry I couldn't give you the exact data. But Dr. Katzen published a study a long time ago showing that he studied nuclear medicine exams from patients undergoing DVT thrombolysis for proximal DVT with just an infusion catheter. And the incidence of a positive VQ scan, which is negligible. So from then on, people in the interventional radiology community knew that positioning a filter during during thrombolytic therapy with an infusion catheter wasn't necessary. Then came all these mechanical thrombectomy catheters. Well, there was an article in 2007 from a group of vascular surgeons, quite renowned, discussing acute DVT therapy, et cetera. And this was published in the Journal of Vascular Surgery. And they concluded that actually there is no data that can determine whether or not we need a temporary filter when using mechanical thrombectomy. It may be intuitively seem like a good idea to some people depending on the circumstances, but overall, the incidence of reported PEs associated with lytic therapy and pulmonary embolus, lytic therapy and mechanical thrombectomy is really low. So, well, when should a filter be placed at all? Well, the indications usually are with free-floating thrombus, contraindication anticoagulation. Those people say, well, if they have one more PE, they're just going to die. Or somebody's already promised them a filter at some other hospital, and then they show up at your hospital, and it's like, is it going to be malpractice if I don't put in a filter? How are we going to get around this? So I wanted to show you a case of free-floating thrombus that we just had within the last couple months. That is a huge thrombus sitting there, and it was waving in the breeze. In fact, there's more thrombus up here that you can't see very well until I tried to go in with an 8 French suction catheter. And I'm thinking trellis might not do anything to this. I don't know. I tried to suck it out, and it bunched it up. You can see it's all bunched up, and now the rest of the thrombus here, this is all bunched up. And it was coming out of the greater saphenous vein, and I did everything I could to pull it out and move it, because this man had a filter put in a couple years ago. I thought, well, if it breaks off, it'll just go to the filter, and then I'll go find it. So I couldn't even budge it. And so I wanted to show you that the IVUS is very interesting. There's a big piece of thrombus sitting right here in that vein. It's partially occluding flow. He was symptomatic, but, and he had an iliac condition that he didn't even know about, actually. But I couldn't move it, and the IVUS didn't change. What we did was we put him on lytic therapy over the weekend. It happened to be Memorial Day, so he got stuck in the ICU for a few extra hours, and the clot completely went away. Well, what about these other issues with DVT thrombolysis using mechanical thrombectomy that kind of like we think beat up the clot? Is there an incidence of pulmonary embolus associated with these? I don't put a filter in most of the time. It depends on the patient's circumstances, like the one more PE issue or how symptomatic they are. But I want to show you that this is a history of a 60-year-old man admitted with horrible DVT, acute recurrent DVT because he failed to take his Coumadin. He preferred vodka. And every time they discharged him, he'd stop the Coumadin and come back. And I told him, I had a long talk with him. I said, we're not going to do this if you're not going to change your lifestyle and go to assisted living. And his family was very supportive. So here, all these contraindications to lytic therapy. So he was the perfect candidate for the trellis. I mean, he had had 3 out of 5 of these major contraindications within the last 6 years. So he was a very high-risk patient. So we did what Dr. Baker, and I didn't know Dr. Baker was doing that, so we simultaneously have done this. Here's the IVC. You can see the amount of thrombus in the IVC itself, in the iliacs, bilateral iliac occlusion, recurrent. And here's the IVC filter, full of thrombus. And here's what I call party trellis. You have, when they're going around, it looks like 2 little balloons at a birthday party. And I didn't know at first if it was, I checked with the rep and I said, has, of any contraindications of doing this? And he said no, and in fact, we were just like Dr. Montero Baker said, there were no problems with doing this. I would show you the subsequent results. We got some debulking. It didn't look that great. This is another picture of how much thrombus was left in the filter itself after the trellis. And then we did also do a lot of aspiration and got quite a bit out, which is very gratifying. And then this was the results after that part of aspiration. It looked a little bit better. But I want to show you the IVUS. The IVUS, if you can see, the lights are kind of diminished the image, but there was quite a bit of thrombus left in there. So we did very low dose lytic therapy overnight, just overnight. And this was the result of the cable venogram the next day. Extremely good, 60 years old. No, he was 60. The clot was probably within a month. It was less than a month, but it had recurrent. That was in October, and he had had his first episode in August. So here's another case. I want to show you this case too. When you get a case like this with all of this thrombus here in the femoral, and you can see that it's extending up from there, and this is the iliac. That's what the iliac looks like. Well, then I did another injection from the right side, and look at this. Look at this thrombus extending up into the cava. Well, I'm coming from popliteal direction, thinking I'm going to treat this young woman with bilateral popliteal trellis and lytic therapy. And I must confess that I did, in fact, put a Optese filter in her from the popliteal approach, which you have to just get a 90 centimeter 6 French catheter, sheath to put it in, push it from the popliteal, because it doesn't come with that by itself. But there is, in fact, a filter there, but the important part is this. Following trellis, I want you to see what it looks like. This happens to be after angiojet and trellis. I'm going to show you some images here, but you see, this was completely occluded acute thrombus, and this is after an angiojet procedure. It shows you kind of a divot in the thrombus, if you will, and the thrombus is completely attached to the wall. So all you get from the angiojet and the trellis is a little bit of debulking in the center of the lumen, and then you seed the clot with the death, the death knell of more TPA just sitting there, so it dissolves after you even do the procedure. Well, this is another image of more clot just sitting there following trellis. It's all stuck to the wall. You couldn't even go in and get that out with a Fogarty catheter. So the question about whether or not you need to, and this is subacute thrombus. Look how much that's stuck to the wall, and here's the IVUS. There's no way that that's going to really go anywhere. You can't push it out. You can't even get it out with a mechanical device. You can aspirate some of that fresh thrombus, but the rest of it that you can't aspirate is really stuck to the wall. So when you see an IVC filter that's occluded like this, do you put a filter above it? No. We just deal with carefully lysing the thrombus and getting rid of that, and then dealing with the chronic occlusion afterwards. And here's, in fact, a patient who came from Minnesota who had a very old greenfield filter here that somebody parked rather low, so it occluded both of her iliacs. Then someone else put an Optese in a couple years ago, and she was completely occluded in both. This is a chronic occlusion. We don't put a third filter in above these patients. We just go in and reconstruct the entire cava and give her back her good flow. And if she stays anticoagulated, which she will at this point, then she doesn't need to have another filter, in my mind. So should IVC filters be placed for thrombolytic therapy? Well, maybe it depends on how rough you're going to be. We're trying to be very careful and do minimal manipulation. And of course, when the trellis balloons are up, they're somewhat protective of anything embolizing. Routinely, no, we don't do it routinely for sure. Almost never is mostly what I do and what Dr. Ossie does. And Dr. Ossie reminds me that I taught him never to put one in. But maybe very selectively I will on an older patient if they have already had a PE burden. And I think not ever is probably not reasonable, because certainly you can make up your own mind depending on your patient's circumstances. And I just want to remind everyone of this experience. When we still declot dialysis access catheters, and the whole technique was just to shove a whole lot of clot out of the dialysis access. And nobody put filters in those patients, and they showered the pulmonary bed with clot from the dialysis clotted access. And those people, I've never heard of anybody dying from that. I didn't think it was a real good idea. I didn't think, how many times can you do this without giving them pulmonary hypertension? But on the other hand, we routinely did that without worrying about putting a filter in, even a temporary filter that might have caught some of that thrombus. So I think the data hasn't been well analyzed. There are no studies that are doing that, but the global experience, the collective experience would teach that you really don't have to put a filter in people in whom you're doing thrombolytic therapy, except very selectively. Thank you. Well, it's a pleasure to invite Dr. Peter Lin to the podium. We've invited him to speak about his experience with DVT as well, and he comes from Texas. And thank you for coming, Peter. Welcome.
Thank you. What I want to talk about this morning is a pulmonary embolism, which is a condition that I'm sure many of you, if not all of you, have some familiar with. This is a condition that can struck patients from all walks of life, and you will likely see them regardless of your specialty, whether you're a physician or nurse or any kind of health professional profession. Now, for the sake of simplicity, I want to classify pulmonary embolism for this discussion into three categories. There's a massive, submassive, and minor. And for the most part, the patients that you will likely encounter are likely in the minor PE category. This represents about 55% of patients who present with pulmonary embolism. The mortality rate is quite low. 15% of them will likely die. And from a hemodynamic standpoint, they're very stable. Most of them don't even have any symptoms. If you would look to take their vital signs, you may see some evidence of tachycardia. They might have some chest discomfort. Now, the other category of pulmonary embolism is called submassive. These patients represent about 40%, less than half of patients who present with pulmonary embolism are classified in this category. In this category, their mortality rate at 90 days is a lot higher. They're about 20%. And if you perform physical examination and perform some diagnostic imaging, such as echo or even EKG, you will see some clinical signs of right heart strength. And that represents some kind of impending right heart failure. They may be very hemodynamically stable because their blood pressure, heart rate has been well compensated, so you may not appreciate any hemodynamic instability. The last category, which is very uncommon, unfortunately they have a very high mortality rate. That's the so-called massive or acute massive pulmonary embolism. They are quite uncommon, and this is a patient that usually presents to emergency room with acute chest pain. They're hypotensive. And the incidence is about 5%, and the mortality rate is very high. In 90 days, death rate is 60%. These are patients that present with a full-blown cardiogenic shock. Their blood pressure is very low, heart rate is in the 120, 130, respiration is in the 20 to 30s. And these patients has acute right heart failure. Now, I would submit to you that patients with massive as well as submassive pulmonary embolism, in some ways, they are interchangeable, because if a patient comes in with massive pulmonary embolism, you institute the therapy appropriately, you can essentially convert them from a massive to a submassive category, hence improving their mortality rate. On the other hand, if a patient presents with submassive and they were not diagnosed appropriately, therapy were not instituted correctly, these patients can slip into a massive category, and hence their chance of dying become very high. So with that said, what are the treatments for patients with these type of category of pulmonary embolism? So historically, this has been validated by a lot of literatures. Patients who comes in with hemodynamically stable status, in other words, their blood pressure is fine, their heart rate is fine, they have no symptoms whatsoever, but yet they have proven pulmonary embolisms. You can start them with anticoagulation systemically with heparin, and additional systemic thrombolytic therapy can also be performed. Now, more recently, we have literature to support that in patients with so-called acute massive pulmonary embolism, meaning that they are hypotensive, they're very unstable from a hemodynamic standpoint, catheter-directed thrombolytic therapy may be of help. Now, with that said, for patients who are lucky enough to receive the thrombolytic therapy or who survive from the pulmonary embolism episode, what happened to them? Now, our cardiology colleague has done extensive study looking at the longitudinal outcome of patients with pulmonary embolisms. And interestingly, they found that 60% of pulmonary embolism patients will have right ventricular dysfunction, and they will go on and develop chronic pulmonary hypertension at 1 year. And this condition will persist even now at 5 years and 10 years follow-up. Now, many of you might ask, well, what does that mean? Well, so they have a little chest discomfort, so what? Well, additional longitudinal study has also demonstrated that these patients, once they develop pulmonary hypertension, their chance of dying becomes very high. Specifically, if a patient comes to the hospital and diagnosed with pulmonary embolism, and they have any kinds of evidence of pulmonary dysfunction on the right side, their chance of dying in a hospital is 4 times higher than those patients who did not have right ventricular dysfunction. And specifically, how do you define that? You can define that based on echocardiogram or CT scan. And right ventricular dysfunction represents a distension in the right ventricle. And if you were to measure their right ventricular size compared to a left ventricle size, and you measure the ratio, if the RV to LV ratio, right ventricular to left ventricular ratio is greater than 0.9, that represents a right ventricular dysfunction, and that's an independent predictor of mortality. And here's a representative CT scan of a patient with a right ventricular dilation. The image shown to your right represents an enlarged right ventricle. If you drew a line measuring the maximum diameter of the right ventricle and compared it to the left ventricular diameter, in this patient, the RV to LV ratio is 1.45. On the other hand, patients to the left, the RV to LV ratio is less than 8. You can see that the right ventricular distance is less than that of left ventricular distance. So in that case, this represents a normal ratio because the ratio is less than 0.9. In this case, it's 0.8. So several years ago, we had some interest in this particular condition, and we analyzed our patient undergoing thrombolytic therapy in those who presents with acute massive as well as submassive pulmonary embolism. Patient comes in and then was diagnosed with pulmonary embolism by CT scan. And then you would perform a catheter directed angiogram. In this case, you can see that there is a large thrombus dislodged in the proximal embolus in the proximal pulmonary artery. Our treatment of choice or strategy has evolved over the years. Today, our preferred treatment in these patients is to perform ultrasound accelerated catheter directed thrombolysis using a so-called ECOS catheter. It comes in with a catheter with multiple transducers, as you can see, and these transducers connected to a generator that emits a non-cavitational ultrasound energy. And the purpose of this energy is to separate the fibrin band. By separating the fibrin band, it actually enhances the surface area of a thrombus, allowing more TPA to bind to the plasminogen receptor. And by doing so, when you emit this ultrasound energy in a setting of thrombolytic infusion, it actually accelerates the efficacy of thrombolytic therapy. And then, so in this case, patient who presents with bilateral pulmonary embolism, we will place a catheter from the groin, and one catheter will be inserted into the right pulmonary artery, and the other catheter will be inserted to the left side pulmonary arteries. And the transducer catheter is also placed in here. You can see these different dots represents the transducer of the ultrasound, thereby emitting this non-cavitational ultrasound energy. In the meantime, we will then initiate the infusion of TPA or thrombolytic therapy. And this is how they typically look. They are very sick. These patients present with heart rate in the 150s, blood pressures in the 80s to 40s, and then they're in the ICU with multiple drips, as you can see here, trying to sustain their blood pressure. You can see here there's a ECOS catheter for the right side, another ECOS catheter on the left side. And they are on the vent, they're paralyzed, these are very sick. And then the machine can actually give you a readout. This is after a certain time. You can see the readout, the energy level, the output based on the time. You can see a progression of the energy output and give you some of an indirect readout in terms of your treatment strategy. And this is a typical angiogram after some 20 hours. You can see in this particular case, the right side that which we're interested in treating, the thrombus has already been largely dissolved. And again, from a schematic standpoint, this is a picture showing a large thrombus dislodged in the right truncal portion of the pulmonary artery. After 20 hours treatment, the thrombus has dissolved. So we've been analyzing these treatment outcomes, and in this chart represents some of the data that we have been collecting. Patients who have pulmonary embolism prior to their treatments under the pre-ECOS strategy, you can see that their pulmonary systolic pressure typically is very high. They present with acute pulmonary hypertension. After treatment, nearly typically 20 to 24 hours, you can see that their pulmonary systolic pressure nearly reduced by 50%. And similarly, the diastolic pressure is also reduced. The pre-treatment average diastolic pressure in the pulmonary artery is about 22 and is reduced down to 14 after treatment. And the mean PA pressure is also reduced typically from a mean of 39 to 17 millimeter per mercury pressure. We have been following these patients. We've been doing CT scan to look at the RV-LV ratio pre-treatment, after treatment, and this represents a finding at 6 months. Patient which presents massive pulmonary embolism, the RV-LV ratio is typically 1.48. Immediately after treatment, it will reduce down to 0.9. At 6 months follow-up, it remains very low at 0.98. Similarly, patient with massive, submassive pulmonary embolism, you can still see a similar reduction of the RV-LV ratio, even which is sustainable at 6 months. So, a couple things that we've learned. In our experience, in patients with massive pulmonary embolism, when we initiate the thrombolytic therapy, we will see appreciable hemodynamic improvement even at 3 hours. So 3 hours after initiation of the thrombolytic therapy, we will see an improvement of the vital sign. Either heart rate will reduce or the blood pressure will improve. And our complication rate is quite low. Generally, it's about 0.1, it's 1%. Our mean duration in our treatment strategy is 25 hours, and the average dose is about 24 milligrams of TPA. More recently, the Seattle 2 trial was presented about 3 months ago in Washington, D.C. in the American College of Cardiology meeting. And this is the prospective multi-center study, which included 150 patients with either massive or submassive pulmonary embolisms. All patients undergoing CT scan demonstrating that they indeed have an elevated RV-LV ratio more than 0.9. Every patient received either unilateral or bilateral thrombolytic therapy using ECOS catheter. And then following their treatment, they were able to demonstrate that the RV-LV ratio or the ventricular dysfunction improved. And RV-LV ratio specifically dropped from 1.55 to 1.13 after 48 hours infusion. This represents a reduction of 42%. Their 30 days mortality in this very, very sick patient population is only 0.7%. One patient out of 150 died. There were no intracranial or any fatal bleeding. There were some bleeding growing complications which occurred in about 11 patients. And other treatment considerations, our goal is to take care of the aiming after the main or the truncal portion, not the segmental pulmonary arteries. And we typically place the catheter in the inferior segment of the pulmonary artery for obstructive pulmonary embolisms. Our goal is to restore the hemodynamic stability, and our aim is to improve the symptomatic from a hemodynamic standpoint. And in summary, we believe that the ultrasound-accelerated thrombolytic infusion for patients with massive PE, even submassive PE, is very useful, and it's very efficacious. And the reduction in RV-LV ratio, i.e. improvement of ventricular function, can be demonstrated even after 6 months following the acute treatment. And in our experience, this is associated with a very low complication rate, particularly bleeding complication rate, which is also affirmed by other studies. And more recently, 2 studies from the Seattle trial as well as the Ultima, which is from the European trial, have also supported the use of this strategy in patients with either massive or submassive pulmonary embolism. Thanks so much for your attention.
Peter, that was a very good talk. Thank you very much. We'll have questions and answers in just a little bit. Now it's even bigger pleasure, if possible, to introduce Dr. Thomas McNamara, who is one of my colleagues who trained in Minnesota as well. Oh, Elder, I'm sorry. You're standing up. Well, I'll introduce you both. Okay, my mistake. Well, Dr. Elder is coming to us from Detroit, actually, and he has been part of the meeting in years past, and so he's coming to talk to us about pulmonary embolism as well. And he is going to are you going to focus on the angiovac experience? Yeah, he has some very interesting cases to share and complement the talk we just heard from Dr. Lin, and then Dr. McNamara will speak.
Thank you. For the sake of time, some of the slides overlap with Dr. Lin, and so he did me a favor by helping me be on time. So I have no disclosures. Objective of this study, we're going to talk very briefly on definition, epidemiology, data review, and then we're going to go over some cases. Definition of pulmonary embolism, as the audience pretty much knows, it can occur from anywhere from the lower extremity or the pelvis, or very rarely in the upper extremity. The epidemiology of pulmonary embolism is an epidemic. There's 600,000 that will have venous thromboembolism, DVTs, which a third of that will present to massive PEs. And of all the patients that die of massive PEs, it adds up more than patients that die from MRSA, AIDS, traffic accidents, or even breast cancer combined. And as I mentioned earlier, it can travel anywhere from the lower extremity. Demographics, I'll skip over this for the sake of time. You see this slide earlier in a different format by Dr. Lin showing that you can stratify the pulmonary embolism by non-massive PE, which is a majority of cases, a little bit over half of them, and then to a lesser extent submassive, and then massive at 5%. The clinical symptoms that present typically dyspnea, hemoptysis, tachypnea, but you can have a bunch of other constitutional symptoms. Diagnostic tools, we have a plethora of diagnostic tools. D-dimer is very helpful as a negative predictor. We usually use markers in low-risk patients of less than 500, and the higher risk, 275. Typical EKG findings is sinus tachycardia, and the VQ scans typically are very effective in a low-risk patients if it's low probability, and in high-risk patients if it's higher probability. The intermediate's not very helpful in the clinical settings. As Dr. Lin mentioned earlier, the echo findings that you see is right ventricular dilatation, some ventricular hypokinesis, and septal deviation. And so here's an example of a normal to the left and to the right dilated RV in a patient with PE. And you also see septal deviation. We see it as a dilated RV bowing towards the left ventricle. We also see some septal deviation in the cross-section, bowing towards and flattening, typically presenting as a D-shaped in the LV. The McCulley sign that you see is hypokinetic RV with sparing of the apical, and you could see that basically in echo, which is a very specific sign. The biomarkers we use is BMP, cardiac troponins, both of which are increased. The BMP is increased because of increased RV shear stress, and then the microinfarction causing elevated troponin, both of which have independently increased mortality, and in combination, they increase mortality and adverse reactions. The PE management, typically, as the non-invasive, non-massive ones are treated conservatively. The massive ones are treated very aggressively, and then the topic of debate is the submassive, which right now the data is suggesting to treat aggressively. And so why should we treat these patients that have submassive PE? This slide is very busy, but it pretty much gathers all the data that we have, suggesting that patients that do have persistent RV at discharge have 8 times more likelihood of having recurrent PE. There's 4 times higher mortality rate with RV dysfunction, and in the patients that have PE, 44%, almost half of them will have chronic pulmonary hypertension, and this is a sequela that will continue on. RV hypokinesis in these patients have a 57% or higher mortality rate than patients that do not have it at 3 months. And full anticoagulation does not really dissolve the clot, and we'll show a little bit of data. This is just another version of the slide that Dr. Lin showed about how you stratify these patients to low, moderate, and high risk. But a quick note about this is that the patients that are submassive are patients that have some type of RV dysfunction, defined either by CT scan or echocardiogram, and so by biomarkers. The massive are very easily defined. These are patients that have some type of hemodynamic compromise or have extreme bradycardia. So the standard treatment for pulmonary embolism is either anticoagulation, which we know does not give full treatment of the clot burden, mainly because it's dependent on the endogenous fibrolysis that's incomplete. And so if we go over the literature, some of which was already presented earlier, we know that the RV-LV ratio greater than 0.9 is an independent risk factor for mortality. We also know there's an 11-fold increase in patients with PE who have an obstruction of greater than 40%. We also know that there's a higher adverse effect with patients that have an RV-LV ratio that's greater than 0.9. And we know that patients at 3 months have a 40% higher mortality when the RV is hypokinetic. And so these patients with RV dysfunction have a 4 times higher likelihood of mortality than patients that where the RV does not normalize. And we know that the chronic pulmonary hypertension is the big sequela in patients that survive the massive PE. And so if we look at the guidelines for ACCP, for selective patients, a thrombolytic is a choice of patients that are not hypotensive. And what they do is they leave it a little bit vague because it's really operator dependent on specific patients. And these patients are massive PE. There's a suggestion of treating it by catheter-based. And the submassive it depends on the patient themselves, what kind of risk factors they have. And I'm going to skip through some of these guidelines to go over to the management. So the management, as we know, is anticoagulation. You can use unfractionated heparin, low molecular weight heparin, but that relies, as we mentioned earlier, as endogenous TPA to resolve majority of the clot. There's systemic thrombolysis that we could use, but the concern with that is the bleeding. We have catheter-directed thrombolysis. Still not enough data to make it the standard of care, but that's where we're headed. There's mechanical and pharmacological interventions, but that's considered a little bit higher risk because of the aggressiveness. And there's, of course, surgical embolectomy. If we look at surgical embolectomy in patients that have massive PE, that are hemodynamically unstable, if you look at the largest registry we have, only 1% actually made it to surgery. And out of the ones that made it to surgery, they had a very high mortality rate. And so these are very critical, unstable patients. And it's very difficult to take these patients to the OR. So endovascular therapy, there's some devices that were mentioned earlier by Dr. Montero-Baker and Dr. Trop about the Trilus. We can use it off-label in the PE. There's Angiovac, which is an aspiration catheter that removes clots, and it requires a perfusionist. And in advance, the next slide. And so what you have here is a catheter that's placed. It's a 22 French catheter that's used for suction, and you can see in the upper screen, this is the placement of the catheter into the pulmonary main trunk, and then below is a 16 French, which is a return catheter. So the clot is sucked out of the catheter, and then it's filtered through the filter pump, then sent back to the patient with a 16 French catheter. So there's really very little blood loss after the perfusionist filters it through the filter device. A very good device. Extensive amount of thrombolysis and thrombectomy can be taken through these catheters. I've removed myxomas, I removed major clots in the right atrium. Very effective. And so this is this is a patient where we're doing an LV-gram as we're using the catheter to suck clot through the left main, or the main trunk extending to the right artery. Angiojet is another device you can use, and pretty much we use it in coronaries and peripherals for Bernoulli effect. It works by suction. The concern is that it's just a small device for the clot burden that we have in the size of the pulmonary arteries, not as effective. As Dr. Lim mentioned earlier about ultrasonic accelerated thrombus, it has its advantages. helps penetrate through the fibrin strands and increase the drug with using a lot less drug. And it helps reverse RV dysfunction. There's enough data that suggests consistency in the data showing that there's RV-LV ratio decrease, including pulmonary hypertension. So I'm going to fast forward this data since it was presented with, very similar to Dr. Lin, eloquently presented some of the data. It showed consistently, but basically the ultimate trial also showed the asymptomatic patients with submassive, and they had very similar results showing an improvement in the RV-LV ratio, improvement in the systolic RV dysfunction, and improvement in the cardiac index. And so they got FDA approval, which is shows consistent data even after approval about an excellent profile and bleeding risk. And so at our institute, we looked at the data when we used this device and other devices, and what we did is we took about a couple hundred patients and we risk stratified them by their morbidity and mortality, and we found that a significant decrease in length of stay in these patients where you're aggressively treating the massive and submassive patients that are hemodynamically compromised or are on their way to be hemodynamically compromised. And so we have a algorithm that we use for PE, which Dr. McNamara will probably talk about, but in our institute, we have one pager that's activated by the emergency room when they have massive PE, and we also have one for the ICU. The same one pager, one team that comes in, very similar to what we do for STEMIs. We have pocket guidelines we have to give the residents. And let me just quickly discuss in the last minute and a half about two cases that we had. One case is a 66-year-old patient that came in with shortness of breath, progressive. CT scan showed a massive saddle embolism, and he was hypoxic, hypotensive, and became very unstable. Sent over to the cath lab, and you can see, this is not playing. There's RV strain. Could you play the echo? Okay, so we'll go backwards. And so we'll skip it, but you have to take my word for it. There's a huge RV dilatation, RV hypokinesis. And if you look at the angiogram to the left, you're seeing massive PE. There's a major saddle embolism that's mobile in the center, and then you're seeing decreased perfusion in the right upper lobe, as well as the left entire lung field. And you see a selective image on the left upper screen, and there's a static image in the bottom showing the massive saddle embolism that's extending bilaterally. And so in this particular case, we rushed the patient to the cath lab. Could you forward next slide, please? And this is an image that's not playing, but shows a placement of the ECOS catheter. And I'm having difficulty forwarding. If you can forward the next slide for me, please. And this is post-treatment in the same patient, and you can see that the saddle embolism has resolved, and it's good perfusion in bilateral upper lung fields. We decided to place a filter despite Dr. Thorpe's recommendation. And the reason why we placed the filter is because there was a free-floating thrombus. Despite having TPA for 24 hours, we subsequently removed it 2 weeks afterwards. And next slide, please. Okay, and so this is pre and post. You can do a comparison. There's the lung fields and bilateral upper lobes and middle lobe. And then on the left is post, and you can see very good perfusion reaching the entire segments. And this is just a static image of the same patient showing the saddle embolism with a CT scan prior to treatment and post-treatment, 1 month. The CT scan showing complete resolution, and it's complete clot burden resolution. The second patient is very interesting. He came in emergency room. They followed an algorithm that I'm sure Dr. McNamara is going to discuss, and they felt that this patient had the clinical symptoms that's very suggestive of a massive PE. In fact, they didn't get a CAT scan. The ER resident actually did an echo at bedside and saw massive RV dilatation, classic McCulley sign, and immediately activated the protocol, and we rushed the patient to the cath lab. And these are echo images that are not really playing, but they show an RV-LV ratio with septal deviation, D-shaped, classic. She recognized it, activated, and we went directly to the cath lab. And this shows a clot selective with decreased perfusion throughout the left lung field. And if you could advance the next slide. This is also another diagram post-ECOS. And advance the next slide, please. And if you can advance to the next slide. And this shows a post-intervention with a decrease in clot burden. So if you can advance the next 2 slides, please. Okay, advance, please. Okay, so the take-home measure points that I wanted to make is the unstable patients. This is life-saving measure. There's very little options we have and less major bleed than using systemic TPA. But we have to recognize the risk factors and ways that we can prevent it. So focus on prevention, prophylaxis, as well as awareness of VTEs. And so in summary, massive and submassive PEs, in my opinion, is still undertreated throughout the United States. The gateway usually is, if they make it, the majority of patients actually that have massive PEs don't make it to the ER. But if they do make it, the ER is a gateway where a lot of these patients can come in. The ICU, cancer centers, orthopedic surgical centers, and any operator can do it, but it takes an operator that has a strong foundation of endovascular procedures and experience treating hemodynamically unstable patients. And this is really the last frontier because surgical option is not as utilized and patients are very unstable. Thank you.
Before I bring Dr. McNamara to the podium, I did want to introduce Dr. Kaki from Cornell at New York City. He's here on the podium to be an expert as well for questions and answers after this next session. And there's one other thing I wanted to just interject here, that a lot of the times if you're going to start this program in your hospital, you'll run up to people saying this phrase, they've got a PE in the ICU or the MICU or the ER, and you'll say, bring them to the cath lab, we're ready. And they'll say they're too sick to transport. And that's when you say this, you say they're too sick not to transport. Because if you don't get them to the cath lab right away, we don't have a chance to save their life. If they sit in the ER or the ICU and go in reverse Trendelenburg and on all those pressors, their chance of mortality is very high compared to getting them to us to help. So with that, Dr. McNamara probably needs no further introduction. Thank you very much for coming.
Excuse me. You're being very kind. Well, as Dr. Elder has said, much of what each of us is going to be showing is we'll be going over some of the same supporting data. But on the other hand, I guess I'm reminded as I was sitting here thinking about that one of the essences of learning is repetition. Is this is what goes forward. Is that right?
Yes.
Okay. Thank you. Initiating a PE program, how do you do that? Well, all of these topics that have been addressed could take a long time to discuss, and what optimally would be good is we'd have a little more back and forth than these formats actually allow. I think that the first thing you have to start with is you have to convince your associates that it's a good idea, because it's actually going to involve more work and more after-hours work, and because it's lytic therapy, which goes on overnight, it's going to involve calls in the middle of the night. And the principle of getting them to agree is hopefully they won't complain then afterwards, and also they'll comply with whatever the program is that you set up. And so it's also, in my opinion, very helpful if everybody on the team, the physician team for sure, is in agreement on the indications and the responses. So when you get a call, everybody says pretty much the same thing. These are the criteria we use to say yes, and these are the criteria we would say use to say no, and the response time. When are you willing to do it? So it's best if everybody's consistent on that, so as not to confuse the referring MDs and generate complaints. Also, we almost never really do this, but I think in a new program, ideally you would have a system worked out in which somebody, at your suggestion or request, sends referring doctors certain key articles which are highlighted. No one's going to sit there and spend a half an hour reading an article. It won't happen. Just highlight the parts that you want them to really see, and just being that it's in an article, it will be evidence-based medicine. They reviewed it, and it helps to convince them. Also, as has been mentioned, the ER really is usually the front door for this, at least in my experience. But after the diagnosis is made, the ER doctors want a disposition, and they always want to get the patients out of the ER. And so it's best if you and your associates or whoever the team is responds quickly and assumes the care, or at least you're part of the care right away. That helps a whole bunch, gives you credibility. And they must realize that you're committed, as evidenced by those things. Hospitalists, of course, as has been mentioned, because DVTs and PEs occur in the hospital. And sometimes they actually need a little more scientific proving. But they like the idea of shorter times in the ICU, and everybody likes now shorter times to discharge, which should be achievable. And also you have to be, and to have them believe that you're competent to manage the treatment, and that's not going to fall on them. They're not going to get that call about what do we do about this oozing in the groin in the middle of the night. So I think one way to do that is every department has a meeting once a month, and usually they're reasonably well attended. Brief presentation and handouts, again highlighted, just to prove that this is scientifically sound and that it's evidence-based medicine, and that they, because these things are published, are at risk of being accused of not providing best care. Same for everybody, but also your technicians and your nursing staff, they can become very enthusiastic about lots of things, and usually are more enthusiastic than you might realize, and they will kind of brag or share with people at the lunchroom, et cetera, and spread the word through the hospital. That all helps, actually. Direct person-to-person. Radiologists have a great opportunity when they call the ER and say, yeah, this person's got a pulmonary embolism, and by the way. And similarly, the cardiologist, when reading the EKG and or echo, if they have a mind to build such a program, that's a perfect opportunity, in my opinion. So how do you persuade? Show the images. Pictures are very, very persuasive. ER docs are used to looking at CT pulmonary arteriograms. Show them dramatic case, pre and post, best if it's one that you can claim to have been involved in. Show data, but keep it simple. And as has been touched upon, and I'll go over much of what's been gone over before very quickly, to try to make the point that it's right ventricular dysfunction. There's lots of ways to do that. CTA is one way, looking then at the heart itself in terms of its byproducts, BNP, troponin, EKG changes. And the risk-benefit ratio should be stressed. That so far, sorry that this is giving a kind of feedback, that the actually, and one slide will be to show that actually in a head-to-head study where patients were treated with just heparin, standard, and the lytic, there was no difference in the bleeding. Now, I'm sure it depends on the operator, et cetera, but nonetheless, it can be achieved that there's no more bleeding than just giving them heparin. And there's every case that people publish, article, shows increased survival and decreased long-term pulmonary hypertension. And it's an evolution, and I'll come to that in a few slides. It's been an evolution in this lytic treatment. Currently, we have certainly what's been the best, is the best at the moment, which is the use of the ECOs. It really does follow the maxim of it's simpler, faster, and safer. Easier, faster, and safer. This is kind of a long, drawn-out slide, but this boils it down here. The problem is elevated pulmonary artery resistance. And the result of that is that you have less cardiac filling, left ventricle cardiac filling, decreased cardiac output, resulting in hypotension, potential circulatory collapse, need for pressors. Coronary perfusion can also be diminished by the decreased left ventricular output, and given pressors on top of that, not a great combination for the myocardium. Lung perfusion is diminished, leading to hypoxia systemically and also in the lung, damages the lung. And perhaps that's why they get chronic pulmonary hypertension in terms of their small vessel vascular bed. Solution: quickly decrease the thrombus burden. And it has been mentioned by Dr. Elder. Anticoagulants, as we all know, don't do that. Now, TPA has been shown to be effective. This is systemic. It actually has been demonstrated in some studies, not every one, to have a decreased death rate. This has been gone over a couple times. And actually, I think a point I'll make, though, is that even in the ones that are minor, still, if you look at the 90-day mortality, is 15%. If this treatment is submassive and massive becomes accepted, maybe I think there will be exploration of using it on these others, if in fact you can reduce that 15% at 90 days to less in the so-called minor. At any rate, why treat PE aggressively? I didn't realize how much data there was about this, and it has to do with all these markers of right ventricular dysfunction. As it has been mentioned, there's a good deal of data. Here's an article from Circulation supporting that just using the RV-LV ratio, that if it's normal when they get out of the hospital, they do much better long term. Here's another one from Chest, very conservative journal. There's cardiac imaging, same sort of thing. Another source of independent, separate articles establishing that the right ventricle is a big deal. Here's another article. This is in the Archives of Internal Medicine. A lot of data. This is going to help you to establish that this is a big deal. I didn't know this. I didn't know this. And another one that, for some reason, actually, the incidence of DVT is higher. I don't quite understand that. Here's just another article, this one from Circulation, talking about pulmonary hypertension. Very, I think, appreciated long-term risk. And then this is a meta-analysis of 1,200 cases, again, saying these same things. RV dysfunction, correct it as soon as you can. Guidelines by Mike Jaafer, et cetera, were, as guidelines like that go, sort of wishy-washy. I like Mike Jaafer a great deal, and he's had a lot of responsibility there, so probably shouldn't have said anything too strong. At any rate, IV TPA has been around a long time, not used. Why? The ear doctor and or the other people are just afraid of inducing an intracranial bleed. People will survive on IV heparin, so as far as in-hospital course, more often than not, they won't give it. At least that's my experience. But some people are so sick that instead of going to the operating room, some patients actually get referred to have mechanical with just a pigtail catheter. Actually, Dr. Kuo in the Journal of Vascular Interventional Radiology 2 years ago published just using catheter-directed therapy. Well, actually, what he was referring, most of those cases were actually just putting a pigtail catheter and spinning it around. You don't really, as it turns out, have to diminish the clot burden and the obstruction much to have them turn the corner and no longer be really at risk of dying right then and there. But ultrasound enhanced is better, faster, safer, and it's available. And so far, this won't last, but so far, no reported brain bleeding. There's no way you can keep giving people lytics and increase the number, and not have some instances of it. But nonetheless, it's appreciably less than others. So coming back to what's simple, RV-LV ratio. Most people now will get a CTA. It actually shows the clot a lot better than a regular pulmonary angiogram. I think there's a lot harder to read the pulmonary angiogram. And so here's what has been alluded to, and you can see on your left the difference in the diameters. It should be that the RV is always less than the LV. Now, if you're going to treat them, systemically versus catheter. Catheter is invasive. Why do it? Well, there's a very elegant example here done in the laboratory in which they had this clot that you can see that's in the right pulmonary artery. Where's the flow go? It goes the other side. Where's the TPA going to go? The other side. So put them in. Put the clot right in there. And that's what I don't know how many years it's been now, 30 years or more, was saying that if you want to get rid of clot, put the drug in the, if you want to accelerate Mother Nature's way of getting rid of the clot, put the drug in the clot. Simple, and ultrasound helps. And that you get this sort of thing quickly, surprisingly quickly. As Dr. Elder mentioned, in 3 hours they can convert from death's door not to. So you don't have to get rid of a lot of the clot. This is Dr. Lin's publication, which he touched on before. I don't know that he made that much of a point of this, that actually there's a significant difference in lytic drug delivered through a multi-site hole catheter, same drug, same dose, presumably, with versus without the ultrasound. Big step forward. And he pointed out that actually in his article that there was a decrease because it's faster and less total dose. It's less bleeding. And then Dr. Engelhardt was one of the first to show in his initial 24 patients. Now he's done more than 57, but reported on 57. Same sort of thing where very quickly they changed this RV-LV ratio problem, and it's good out to 90 days. This is an article by a radiology group in Florida. They treated massive and submassive. If you look on your left in yellow, massive PEs amounted to 20%, submassive 80%. Then you look to your right, the second group box down, 90-day survival, submassive at 90 days, 98%. Massive, 75%. Pretty darn good. Bleeding, insignificant. And this just is another method of showing that in a comparison of heparin, which is the blue boxes, versus the ultrasound with the echo, far left is a baseline reduction. The reduction in baseline RV-LV ratio in 24 hours. It was diminished by 30%, that ratio, whereas on heparin at 24 hours diminished by 3%. Now you go out to 90 days, and then the endogenous lysis helps catch up, but you're still not back to a normal. Looking down, the third row down is major bleeding. Red is the ECOS plus heparin. Blue is just a heparin. Major bleeding, 0, 0. No more bleeding with this and with heparin. So how to do it? Well, you're either going to come in and do it right away if that's what the situation and or the doctor wants, or if you can say, if they're stable, they're normal intensive, that's what puts them in the submassive category by clinical criteria. How about if I do it first thing in the morning? They'll be stable, they'll be NPO, and everybody, it's better in many ways. And if they go for that, fine, do it, but bump whatever's on there so that you can really do it right away the next. I don't think it actually makes that much difference in a submassive, but that's just an opinion. Follow-up protocol, as Dr. Elder mentioned. Everybody knows it. You know it, your partners know it, the nurses know it, techs know it, etc. And it decreases anxiety, mistakes, night calls, and so your goal is to have everybody, the ER, the ICU, your associates, the staff, all say, oh, these are easy cases. And they can be. Remember the 3 A's. Availability, no problem. Now we're heparinized and do the first case in the morning if the systolic pressure is more than 90. Affability, terrific. Thanks for the referral. Oh, happy to do it. Oh yeah, and I'll keep you posted. And and then a little personal note that never hurts. And ability. So it's availability, affability, ability. And the bottom one, we all strive for this, but it is important to, you're promising the good results, and you should deliver. Thank you.
10:15. Do you want to just take some questions and answers and save the case for afterwards?
Oh, the cases are pretty quick. What's up to you?
Well, we have to break at 10:15. So.
Sure. Questions. Great.
So.
Great. Questions. Sure.
Sure. I'd like to open the floor to any questions for the panel right now. We have a couple minutes for questions before we go to a break, and then Dr. McNamara can show an interesting case after the break. Anybody have a question for the panel? Yes, please.
Yes, I'll do a quick question. You have somebody that came in from home, found basically collapsed in the floor. But now at the ER, his tachycardic has 100 systolic. Would you consider that a submassive or a massive PE?
Dr. Lynn?
So I understand how the terminology is being used. They're actually using 90 systolic blood pressure as a way of dividing clinical massive in terms of response to the clot burden versus submassive. So if they're above 90, at least in terms of publications, they would be in the submassive group. So your 100 would be submassive clinically.
Well, my point is that what probably his blood pressure when he collapsed was, 70, 60. We don't have documentation, but you probably, when you do the echo and the CT, you can demonstrate massive amount of thrombus, a huge dilatation of the RV. So I don't know if that will be, definitely for me, that would be a case that I will treat. But if you ask me, and this is just an opinion, the fact that we don't have documentation that guy probably had a 70 systolic when he collapsed, it's probably a massive PE in the beginning. Now he improved somehow.
I think the terminology, it's important to have terminology agreed to. The terminology doesn't really follow the volume of clot. That's Frank Miller's category of it, and it was important for quite a while for reporting purposes, but now it's the clinical response. And although the patient obviously had a blood pressure much lower than 100 when he collapsed, nonetheless, now he's at 100. So from a categorization he probably would fall into, because as I think Dr. Elder and Dr. Lin would agree, and if not, hopefully they'll say so, the patient has RV dysfunction. Both the massive and the submassive will have that. The differentiation clinically currently is blood pressure. If it's over 90, the current definitions are submassive clinically, under it, massive clinically.
That's a good question, and there may be some dispute, but when you go to the patient themselves, when you look at that type of patient, the patient who is at risk for dying within the next hour or so has a dreadful sense of foreboding. They're not sitting there being relatively asymptomatic despite the numbers. So you have to put the whole clinical picture together. And would anyone else like, Dr. Kaki, would you like to comment on that, please? With regard to, the systolic pressure itself.
The definition we use at our institute, we go about 15 minutes of documented blood pressure less than 90. So if you have an episode of 15 minutes, and although they might stabilize and go to 110, 120, that would suffice. Or a 50 millimeter decrease from the baseline systemic blood pressure. Patients come in, they're running a blood pressure of 160, and then now with respiratory distress, now their blood pressure is 100. If it's greater than 50, we consider that massive in our institute. I know, Dr. Kaki, if you want to elaborate on that.
Yeah, and one thing that wasn't discussed in these patients that you described, he had persistent hypotension when he was diagnosed. What we noticed is that these are usually massive, involving the main pulmonary artery. We've had writing up about 3, maybe 4 cases anecdotally where we performed balloon angioplasty to the main PA before we took the ECOS catheters. And actually those patients lived, and they actually stabilized soon after the angioplasty. I don't know if any other people on the panel are doing that for main PA.
Well, I think that we've had that experience of breaking up a massive obstructive embolus and fragmenting it, and it starts the process of perfusion. So it does make a huge difference just to break it up. I think we've on that. Would anyone else like to add anything?
The blood pressure is just one of many elements that we look at, because there's many things you need to look for. Because by definition, besides the blood pressure as a factor, patients who are massive, by definition, are in cardiogenic shock. So these patients are oliguric. And we actually pay more attention to the blood gas. So obviously the initial step is to resuscitate and put them on FiO2 to improve their oxygenation. In the meantime, you got to get a CAT scan. Now, the other definition, which we didn't talk about, is you can look at the presence of clot in the pulmonary artery based on the so-called Miller score criteria to define whether they have acute massive versus submassive. At the end of the day, the decision you need to make is, do you put them in ICU to start systemic heparin, or do you take them to cath lab to initiate thrombolysis? So blood pressure, if it improved, you can potentially convert that to submassive and continue with systemic heparin. That may turn into minor PE. That would be fine.
So one more question then, Al. I have a big problem convincing both some of our cardiologists and pulmonary docs that treat people in the ICU to treat even the massive PE with thrombolytics. They just don't want anything to do with it. And I've given conference, I send the guidelines, and I see no interest. So should I just go over to the medical director, try to develop a program like you guys have? What should be my next step?
Do you have direct access to your own patients? I mean, I work with Dr. Elder now, but what we did is we had little initially resistance, and what we did was with our own patients that had acute PE from the emergency room, we demonstrated safety, which was a concern from our referrings and from within our institution, and efficacy. We actually wrote up the data in regards to length of stay to show that it was a win-win for the patient, for the hospital, and the institution. And since then, we've had tremendous traction and a lot of support. The hospitals, like Dr. McNamara noted in his talk, is that they're very appreciative if you decrease the length of stay. The other thing is a lot of these patients are old and sick, and the fraction of the lytics that we have to give and the fact that their bleeding risk is almost nil for intracranial compared to systemic lytics was also very positive in helping us start the program. So those are kind of things that we did.
I think unfortunately it ends up being more a political issue. than a clinical, and that's very sad. In our case, we had to actually create a financial excuse to get all the hospital administration on our side to understand that we could actually minimize the ICU costs and stays. And that was actually the final push. And then with that, we created we brought a bunch of services into grand rounds and try to create that mentality. And we still, to today, have this fight with some pulmonologists of the older pulmonologists in the hospital that still don't believe in this and think that it's just hoax.
I think we've all had that experience. Another question, please? I'm sorry, sir, could you go to the microphone so we could all hear your question, please?
I think his question was, how long do you keep the ecos in?
Following ECOS, do you give overnight TPA?
Well,
You
ECOS
mean
is
after the ecos catheter is out?
Yeah, if ECOS catheter is out, or can you give overnight TPA with the ECOS catheter or no?
ECOS does deliver the TPA with the ultrasound bubbles. It's a simultaneous
No, but
process.
I mean after you have treated it, you remove the catheter and
So I think the question
hepatic
is,
the patient?
I think your question is like injective therapy or as a supplement?
Yeah, as a
Yeah.
supplement.
Yeah, well, I guess my personal experience, the whole purpose of using the ECOS is using a small amount and concentrated. So, I never use any supplemental TPA afterwards. A few times when we use the ECOS, so there's a little bit more clot burden, you can just extend the time. I typically use it for about 15 to 17 hours, and I'll extend it for extra 5 to 6 hours. And I'm not sure if the panel does it differently, but I tend not to use any supplemental TPA afterwards.
Well, that's what I meant, if you leave the catheter.
Thank you.
I have actually a question I wanted to pose to Dr. Lin. It was in regards to once you have your ECOS catheters in, and as we spoke in here, that there's all these hemodynamic parameters we could follow, including the patient's response to the FiO2, how their vent management starts getting, kind of like looking better, and their bedside echo could be better. My question is, and probably also to the rest of the panel, do you take them back for an angiogram, 12, 24, 48, whatever hours, or do you just based on the betterment of the clinical aspect, just pull the catheters out bedside in the ICU and then allow the team to kind of take over?
It's good. It's a great question. Our treatment strategy has evolved somewhat over the years. Now we would routinely do echo at bedside. Just a word of caution, because the ECOS catheter does emit ultrasound. When you do a bedside echocardiogram, you do have to turn the machine off. Otherwise, you get a lot of conflicting artifact from the ultrasound energy wave. So you do have, for the moment that you're doing an bedside echo, you turn off the ECOS machine, but you can still continue with the lytic infusion. We routinely take them back right around 24 hours for completion of venography, also for documentation. There has been 2 cases we had to pull the catheter at bedside, in part because of bleeding-related complications. But by and large, we do take them back for repeat venography in 24 hours.
Well, thank you. The time is now. Do you have one more question? The time is 10:20. We're going to have a short break. We'll take one more question and then we'll go.
So for ECOS, my question is, there are a few absolute contraindications for TPA. By using ECOS, do we actually can use in those situations for absolute contraindications by lowering the dose of TPA? Like you said, 1 milligram per hour, can we go down to like 0.5 milligram per hour? Because these patients are at a life or death situation. Do you actually speak to the patient's family, or is it allowed to do? You guys do it or not?
It's FDA approved to use both the lytic therapy since 1981 for PE, and now the FDA has given an indication for ECOS. Is that your question?
No, my question is for patients with absolute contraindication for TPA. Can you still use ECOS?
Would you like to answer that? Yes.
Okay, so we have a few scenarios. Now, understand that systemic TPA, you're using about 100 milligrams. And in the standard case that we use, we're using about 20 milligrams, sometimes even less. And we had a few cases where it was contraindicated, but there was no other choice. And as for life-saving measures, we used 1 milligram an hour for 4 hours and went to 0.5 milligrams, which is pretty much half the dose. We had enough results. We still had some clot burden, but hemodynamically the patient stabilized and we were able to get successful results. So in patients that are absolutely contraindicated to TPA, in extreme cases where the patient had no other option and it was a life-saving measure for heroic measures, we had a full discussion with the referring physician as well as the family members, and they had reasonable expectations, but fortunately it was successful using it half the dose. And so we were able to use roughly 12 milligrams of TPA.
Okay. I was thinking that, would you just go for the angiovac rather than going for the ecos at this situation?
The angiovac is a little bit more complex. There's a lot set up to it. And so in a very acute, unstable patient, it's not something that you could do ad hoc. It requires a perfusionist. There's 2 to 3 operators that need to come with you, and the access is a little extensive. So it's not a procedure you would use for someone who's unstable, hemodynamically crashing. You'd have to use other measures that you can quickly get in there.
Thank you.
Thank you. I'd like to encourage everyone to go in and see the vendors this morning during the break, and we'll meet back here in about 15 minutes at 10:35. Thank you. Thank you.